Hematological complementary and alternative medications. There are numerous agents utilized to help maintain, preserve, restore circulation, and this is what we're going to be talking about. The three important dysfunctions of the blood are thrombosis, which is a blood clot, bleeding, which could be like hemorrhaging, and anemia. And these are commonly treated with various agents, which some of them you probably have already heard. Your anticoagulants, your antiplatelets, your antifibrinolytics, your thrombolytics. And medications like that. When we talk about the complementary and alternative medications, we're talking about with complementary, think about you're using it to a medication to help help the hematologic. Maybe you're going to give an antiplatelet along with maybe an antifibrinolytic to kind of help maybe prevent the formation of a blood clot. Alternative medications are just what it is. It's kind of like thinking outside of the box. Other medications that maybe are meant to do one thing, and the side effect of it is to help maybe prevent the blood clot, to keep the blood thinner. But it's also could be that it's something that maybe if you take it is going to cause you some bleeding problems with it. So moving on, one of the things that when we talk about stopping bleeding and stuff, we're going to talk about hemostasis, and this is a general term that is used for any process that stops the bleeding. This could be through mechanical means, such as you're applying compression, you're applying a tourniquet to stop the bleeding. To maybe somebody's cut their hand, so you need to staunch the bleeding, so you're applying pressure to it to stop the bleeding. Or through maybe surgical, when somebody has been stabbed and they've nicked the femoral artery, so they're going to go in there, they're going to clamp it. If they're doing surgery, they may cauterize it, they may stop the bleeding with it that way. So that's what we're talking about. When you hear hemostasis, just think that it's the general term that they're using for any process, mechanical or surgical, to stop the bleeding. When hemostasis occurs due to a physiological clotting of blood, it is called coagulation. This is what we want it to do. If you want something to stop, you want the blood to coagulate. And just think of this. This is the process of blood clot formation. This is where your coagulation is basically just taking something that is very thin and making it kind of a thicker, viscous, kind of a sludgy type thing to stop the bleeding with that. So when you think of a puncture wound through, like somebody has stabbed you in the arm, and in order for you to not bleed to death, your body kicks into action. So this is where your platelets and your fibrin and all that stuff all gather together and form that blood clot to plug that hole to stop the bleeding. The technical term, just remember, you're going to hear this used either interchangeably. You're going to hear thrombus, you're going to hear blood clot. Just keep in mind, they mean the same thing. A thrombus that moves through the blood vessel is called an embolus. So if you hear when we talk about pulmonary emboli, that means the blood clot maybe has started someplace and has moved through the vessels and has lodged itself in the lung with it. So throughout the lecture, you're going to hear us talk about a couple of different things. And one of them is you're going to hear us talk about normal hemostasis, which is basically the promotion of clot formation. And the other one is also breaking up the clot or preventing the blood clot with it. So substances that we're going to talk about that promote coagulation include platelets, the von Willebrand factor, activated clotting factors. These are some of the things that we're going to talk a little bit more about as we get through the chapter with that. So throughout here, you're going to hear me talk about some medications that some of the medications are given orally, some of them are given sub-Q. None of them are given IM, but a good majority of them are also given IV. As LPNs, no, you cannot push anything through the IV, but you still need to be familiar with those medications because some of them do have like a half-life, or the duration will be 8 hours, and they may have got it down into the cath lab, and you're taking care of them for 4 more hours after that procedure. So you need to know how to watch for side effects and stuff like that on that. Coagulation. If you look on, we've already talked a little bit about what coagulation means, but if you also look at Tabor's defines it as the clumping together of blood cells to form a clot. It occurs in vitro, intravascular, or when a laceration of the skin allows the escape of blood from an artery, vein, or capillary. Coagulation of blood may occur in two pathways depending on the beginning of the process. When we're talking about the pathways, we are going to talk about what they call the coagulation pathway. These are going to be found on page 413 in your book. These are the coagulation pathway can get really in-depth and detailed, but what I want you to take away from it is kind of how one factor will lead, what one injury or one cause of bleeding is going to lead one way, and another cause is going to lead another way, of how the body deals with clotting factors and stuff with that. So, the coagulation system is called a cascade or coagulation cascade because each activated clotting factor serves as a catalyst that amplifies the next reaction. So it's going to, by that it means it's going to be, one thing is going to start the process. It's going to get things rolling with it. And we'll talk a little bit more in detail about that. On that. I just want you to have an understanding that of what coagulation is. It is, like I said, you can find a big lengthy one in Tabor's on 497. It talks to you about what that is, and it also discusses the clotting, the coagulation pathway, or the books is just as good too with it. Just remember, coagulation is just the forming together or the clumping together of blood cells to form a clot. Everything is going together to form a clot, and its main goal is just to stop the bleeding with that. Now we're going to talk about the process, some of the substances that help promote coagulation. Platelets, which we talked a little bit about it, which are part of the clotting process. They're kind of like the binding part of it. When there's an injury and there needs to be the start of it, platelets kind of help play a part of it. They have a protein that allows them to be sticky and allows everything else to kind of attach to them to help form the blood clot with it. On page 421 of your book, it kind of shows you just a little bit about the cyclooxygenase pathway and stuff. It talks a little bit about the platelet effects on that. With platelets, remember, they normally flow through the blood vessels without adhering to the surfaces. Once the blood vessel has been injured by disruption of blood flow trauma, this is when, the platelets kick into fact. It's the stickiness, the collagen and stuff from the injured cell vessel wall. It kind of like flows onto the platelets, and the platelets kind of get stuck into that, which is where you start the formation of, the blood clot with it. The platelet is at the prostaglandins and stuff are released from the activated platelets, and this has caused the platelets to then accumulate and then to form the blood clot. So basically what happens is, what I want you to take away from this part is I want you to understand platelets, they flow through the blood. Once there is an injury to the blood vessel, collagen and plaque and stuff, all sorts of substances and fibronetics, enzymes and stuff are released into the blood system, and they are really sticky, so they kind of attach to the receptors of the platelet, which causes them to, accumulate at the site of the injury. So the platelets are going along, and all of a sudden there's like a stab wound or something in the vessel, and it's releasing all the collagen and glycoproteins and stuff like that, and they're sticking to the platelets, and it causes the platelets to accumulate there at that one spot, and then that's when everything else starts accumulating or sticking to the platelet to cause the blood clot. Now, the von Willebrand factor is another glycoprotein which is important in the homeostasis of the hematologic system. Remember, it's just part of a protein that allows you to stop the bleeding. in the disease part of it, it's missing, so there is no ability for the person to start. You see that with like hemophilia with it. Now, activated clotting is just the activated clotting factors are just factors that we're talking about that once there is an injury and stuff, that signal to the body, we need to start clotting. We need to, release the collagen. We need to, release some of the glycoproteins. We need to get, the stimulators, your adenosine, your diophosphate, your thrombin, and some of those things going so that they, we've got all this sticky substances and stuff going so that we can get an accumulation of your platelets with it. And that's also what, we're talking about when we're talking about the tissue thromboplastin with it. Excuse me. So you're looking at, starting of an event that is going, release of things that, thrombin, things that are going to cause the thrombosis that are going to, that are being released to help produce the blood clot, to help the hemostasis, to help the body stop the bleeding with it. Okay, next we're going to talk about prostacyclin. This is a substance that inhibits, one of the substances that inhibits coagulation. You can find it on 421 in your book. Prostacyclin is a compound formed from metabolism of araxinoid acid. It's a potent vasodilator and inhibitor of platelet aggregation. Basically, it helps with vasodilation, but it also inhibits platelets from aggregating, clumping together, forming together with it. So usually if you see a medication and it says it's prostacyclin, this is what it does. What they're giving it for is to prevent the platelets from gathering together and forming a blood clot. The next one, also found on page 421, are proteins C and S. Protein C is a plasma protein that inhibits coagulation factor 5 and 12, preventing excessive clotting. Deficiencies of this protein or resistance to its effects may lead to DVT and pulmonary embolism. Protein S is a vitamin K dependent protein that acts with protein C to prevent blood clotting. Deficiencies may lead to venous thrombosis and pulmonary embolisms. So these are ones that they can run labs on, and they will see, okay, if they're if you have somebody that has maybe a history of pulmonary embolism or DVTs, they'll run in that and they're seeing if maybe there is a deficiency in these proteins. And if there is, then they're going to treat it so they can prevent any future DVTs or emboli with that. Antithrombin 3, which is found on page 414, it's an antithrombin. Just think about it as antithrombin. Anti means it's preventing, it's against, and it's against prevents the action of a thrombin. So when you look at antithrombin 3, we're looking at a plasma protein that inactivates thrombin and inhibits coagulation factors, preventing any abnormal clotting. When we're looking at the coagulation factors, we're looking at 9, 10, 11, and 12 with that. So, excuse me, don't get so hung up on the coagulation factors with that and stuff. You really don't need to commit these really to memory at this point in time. You just need to understand that when they're given an antithrombin 3 medication, what they're giving it for is they're trying to inactivate the formation of thrombin. They're trying to prevent the coagulation. And sometimes you will see this given in patients maybe like that have had stroke from a blood clot, not a hemorrhagic stroke, but maybe a blood clot. With that, they're giving it to somebody that has an issue with a blood clot, such as like with DVT and stuff like that. Okay, the coagulation system is called, we talked about this a little bit at the beginning of this, is called a cascade. You're going to hear it as a coagulation cascade, coagulation pathway with it. As each activating clot factor serves as a catalyst that amplifies the next reaction. Basically, there is one thing that starts the reason. There is a reason that, a blood clot forms. A blood clot just does not form willy-nilly. It forms for a reason. So once you have that catalyst, you have that reason for it to start, then it amplifies and starts things working. Okay, the result is a large concentration of clot-forming substances called fibrin. Fibrinolysis is the reverse of the clotting process. So when you see this, when you see a fibrinolysis, lysis is destroying. So when you see these together, we're reversing the clotting process. We are stopping. We've had the start of a blood clot. So we're giving them medications. We're breaking it down. We're lysing that thrombi. Plasma is an enzymatic protein that eventually breaks down the fibrin thrombus into fibrin degradation products. So there's a whole process of it, and the whole process is meant to break down a blood clot or a thrombus that has already been formed. Coagulation cascade. The definition starts on page 412, but if you look over on page 413 in your book, you're going to see the pathways. You're going to see the main two different pathways that are involved in this. Now, before I go on, don't hyperventilate. Take a deep breath. I'm not going to expect you to have this memorized. This is something that you really aren't going to deal a lot with as far as the steps of it. You just need to understand the basics of the two different pathways. I'm not going to expect you to know and memorize each factor with it. I've also uploaded on Canvas some videos that are going to hopefully help you bring a better understanding, maybe explain it a little bit better than I can with the coagulation cascade. The importance of the coagulation cascade is just kind of help you understand a little bit about how some of the processes begin and how the body reacts to it, and sometimes how the choice of medication that the doctor is choosing maybe be used with it. Okay, so we talked a little bit about coagulation cascade at the very beginning. The coagulation system is called a cascade. Think about cascade as basically a series of steps, each of which begins the next. So basically, when we're talking about the coagulation cascade, we're talking about coagulation steps. What happens, step one, and then kind of the steps that are going to go afterward to get to maybe the hemostasis, the stopping of the bleeding, or the dissolving or the degradation of the blood clot. Okay, so the coagulation cascade is activated. Each one of the different pathways is activated in a different manner. Something amplifies the next reaction. Something starts it and it just kind of builds up on with it. It is divided into intrinsic and extrinsic pathways, and these pathways are activated by different types of injuries. When blood vessels are damaged by penetration from an outside, external trauma, thromboplastin, a substance contained in the walls of the blood vessels, is released. This initiates the extrinsic pathway by activating the factors 7 and 10. So when we're talking about the extrinsic, just keep in mind external. It's something that has happened externally. Something that maybe like a stab wound, a bullet wound. Somebody has been impaled and it has damaged one of the arteries or vessels with it. Something that has happened from the outside to damage what is on the inside with it. So that's kind of how you can keep the extrinsic. Just think extrinsic, external. Now the next one is intrinsic pathway, and the components of that are present in the blood in their inactive form, and the pathway is activated when factor 12 comes into contact with exposed collagen on the inside of damaged blood vessels. So when you're thinking intrinsic, think internal damage to the blood vessels. So something has happened internally to the blood vessels, and this starts this clotting factor with it. if you look on, like I said, page 413, figure 26-1, this is for the extrinsic or external trauma. 26-2 is the intrinsic or internal damage to the blood vessel. It just kind of shows you step one and kind of walks you through how, the factors are inactivated by heparin or vitamin K dependent clotting factors when we're talking about that. So don't get too bogged down with it. But what I want you to understand for the, for future reference and to focus on is the difference between intrinsic and extrinsic with it. Okay, continuing on. Both these pathways, they'll illustrate the steps that occur in each respective pathway with it, and the coagulation factors that are involved with it. This also, you notice it has heparin on there, so it kind of illustrates the site of action of two commonly used anticoagulant drugs, Coumadin and heparin. So this is kind of where if you look at the external trauma, you see that you've got the clotting factor 12, and then you're going to go activated 12. So it means, it's just kind of how the system works. It gets kind of confusing with them, so this is why I'm not going to expect you to memorize all the factors. I don't want you to. I want you to focus on other things for the test with it. So take a deep breath and relax, and don't worry about memorizing all the factors with it. Okay, on this slide, this is a simpler version of the extrinsic pathway. You can see in step one where it's got a release of tissue factor. Traumatized tissue releases a complex of several factors called tissue factors or tissue thromboplastin. Step two, activation of factor 10. This tissue factor further complexes with factor 7, and in the presence of calcium ions acts enzymatically to form the X factor. So you can see where it just is showing. I want you to focus more on the other side of it where you see the diagram, the blue arrows where it says tissue trauma, arrow down, tissue factor, and it kind of just shows you how it is. Like I said, I'm not going to ask you the steps or the process of this, but you just need to have a general understanding of how this coagulation cascade works, how the steps in the coagulation work, depending on how the injury has happened with it. And like I said, I posted a video from Khan Academy about it, so watch it, and it will kind of go into a little bit more detail, and it will explain it in better terms than I probably can. It'll help you understand it just a little bit better. Okay, here is the intrinsic pathway. You can see where it's talked. Step one, blood trauma causes A, activation of factor 12, B, release of platelet phospholipids containing platelet factor 3, and you can see where it just kind of walks you through the steps with it, and it takes you down to the formation of thrombin. This is taking you from the injury down to the formation of thrombin. And question, and I hope everybody knows it, what is thrombin with it? Keep that in the back of your mind, because that is probably that question may or may not show up on your test, but it may also be thrown at you later on, especially when we start talking about cardiac meds, cardiology. So you need to understand what thrombin is. And also it may show up somewhere, the word thrombin and prothrombin may also show up during Lonnie's lecture of neuro with it, especially when she starts talking about stroke. So get familiar with the word thrombin, blood clot, used interchangeably with that also. Okay, and this is just kind of an overview of major components of hemostasis. Remember, it's the stopping of the blood clot. You can see at the very top where it has vascular injury, where that all that blue is and stuff, where there's the injury, and you can see where the arrow slides over to step one where there's vasoconstriction. You got platelet activation. You can see where there's tissue factor, and it's releasing all this stuff. So I found this, and I kind of hoped maybe this might, with the more visual ones of you, if this would help you just a little bit of that. Once again, I'm not going to ask you to specifically say, okay, I'm not going to plop something on the test and say, okay, major components of hemostasis, draw it for me. But you need to have an understanding of what happens when there is a vascular injury. Okay, it's going to cause vasoconstriction, platelets are going to be activated, then the coagulation cascade, depending on how it is, extrinsic or intrinsic, and then it's going to go from there. You're going to have the platelet plug, which is going to go to your fibrogen, which is going to be your fibrin, your blood clot. Boom, there you go. It may continue on to something else. It just depends on what is going on with it. So I hope I hope visually will kind of maybe help you see how hemostasis works, clotting, the formation of the clot, how the whole system works with that. Okay, pharmacology overview. Drugs that we're going to talk about some of this, and this is very important, and you're going to hear about this. We've talked a little bit about injuries, sentinel events, and things like this, things that we need, you've heard us talk about things you have to be really cognizant of, things you need to pay attention to. This is one of them. Drugs that affect coagulation are some of the most dangerous drugs used today. They can cause bleeding instantaneously. They can cause death if not, abnormal lab values are not caught. So that's why we stress, before you give your Lovenox, check the platelet count. Before you give Coumadin, check the PT-INR. If you have somebody that's blood pressure is going really low and they seem to be shocky, are they on blood thinners? Have they fallen? Have they hit their head? These are some of the things that you need to kind of keep in track. These are some, like if you're working in the ER or you're working in the nursing home and a resident has fallen and they're starting to bleed. Are they on Coumadin? What do you need to do? Do they have a subdural hematoma because of the Coumadin that's caused the brain bleed? Those are things that you need to start critically thinking about. The National Patient Safety Goal, this was implemented by JCO in, I believe, 2006, and it's for the safe usage of the drugs. Hospitals are required to take steps to prevent adverse events associated with these drugs. Here are some links that will take you to them. The other thing is, even in long-term care, assisted living, the regulations are such that if you have somebody on Coumadin therapy, you either, before you can administer the Coumadin, then you must go and you must look and see what their last PT-INR was done, when it was drawn. If it has not been recent, if the doctor says he wants it drawn every month or every 2 weeks and it's been 2 months, then you need to call right away and get, hold of the doctor and say, okay, if it's 5 o'clock in the evening and you're supposed to be given the med at 5:30 and it's somehow got missed, that it hasn't been drawn and it's overdue, you still need to call the provider and say, hey, look, I'm going to be giving this Coumadin. The person is on 3 milligrams of Coumadin. The last PT-INR was 2 months ago. It was this level. Do you want me to go ahead? It was 1.5. Do you want me to go ahead and give it? Do you want me to hold it? What do you want me to do? And follow the recommendations of the provider. So it's very important. This is what these goals are. CMS picked up, and JCO kind of sometimes will go hand in hand with some of the regulations, and this is one of them. Also, if you've ever had to do a fall incident report, this is one of the things that it looks like. It's going to ask, in long-term care and in the hospital, it's going to ask, is this patient on blood thinner? So they're wanting us to critically think and to follow certain pathways, say, yes, this person fell, this person has had an injury and they are on blood thinners, this is what we've done, the doctor was notified, this is what we've done to either maybe we've stopped it, we've increased it, whatever. So the facilities and the providers and staff have to show the steps in. Yes, we're monitoring it. We know what is going on. We know what the levels are. This is what we're doing with it. So this is where documentation also and communication is very important. Okay, now we've got kind of like the background of this taken care of. Now we're going to start talking about the medications and kind of how they pertain to patient care. The whole idea of pharmacology. All right, anticoagulants, excuse me. They're also known as antithrombotic drugs. So if this is kind of like thrombus, blood clot. These are also anticoagulants or antithrombotic drugs. Anticoagulants when you're looking at them, the definition of them is they interfere with coagulation process by interfering with the clotting cascade and thrombin formation. They go in there and they get in the middle before it gets to the blood clot forming in between the fibrin and the platelets and stuff, and they prevent it from being sticky and collecting together, and it prevents the clotting factor. It prevents the thrombin from being formed. Excuse me. These agents, they're used to inhibit clotting factors, but they do not dissolve existing clots. That's very important to remember. They work at inhibiting clot formation, but if there is a blood clot already there, it's not going to dissolve it. It's not going to do anything about that blood clot. All it's going to do is prevent further blood clots from developing. And once again, it talks a little bit about the coagulation, the clotting cascade. So just kind of basically know that in the clotting cascade, an anticoagulant, it works in preventing the clot with it. That's all it does. It works at preventing any future clots. If there's a clot already there, it's not going to do anything with it. So don't think you're going to be given Coumadin to help dissolve a blood clot that's already there. That is not what you're doing. You're giving it for. You're giving it to keep the blood thin, so it does not cause any blood clots. Okay, anticoagulant indicators. Used to prevent intravascular thrombosis or blood clots by decreasing blood coagulability. It keeps the blood thin. Indicated in high likelihood of clot formation, and that you're usually going to see Coumadin given for people that have had an MI, they have unstable angina. It means the heart's not pumping. Think back to cardiology, AFib. If you have somebody with an irregular heart rate, the blood is not being pumped out of the ventricles like it should, so it can maybe kind of pulls there, so it allows the blood, to kind of coagulate and get thick in there and cause a blood clot. So that's why typically if you have somebody that has atrial fibrillation, they're going to be on Coumadin. They're going to be on something that is going to thin their blood. They're going to be on an anticoagulant. They're also going to see it on people with mechanical heart valves because you don't want anything forming on it. You want to keep the blood thin going through the mechanical heart valve. Orthopedic surgery, they will give it. It's not going to be necessarily a long-term treatment, but they're going to give it for a short term, maybe 6 months or a year, to make sure that the blood, they're not having problems. Because orthopedic surgeries, those are longer surgeries, so sometimes the blood can pool and not do what it needs to, and a lot of times there may be a blood clot, especially if you're doing like a hip surgery or something. So they'll give it after an orthopedic surgery to help kind of keep the blood going. Also for prolonged periods of immobilization. With it, somebody that is on bed rest, they might be getting maybe Coumadin or Lovenox to kind of help them, keep their blood thinner. I know when my dad was in the hospital and stuff, and he was in bed, he had influenza B really bad, and he was in bed for probably a good 5 days except for maybe getting up and going to the bathroom when he was having diarrhea. He was on Lovenox to help, and he had on TED hose, and they did the alternating compressions, the SED boots and stuff to help keep the blood flowing because he wasn't getting up, he wasn't moving. They did not want him to have a development of blood clots with that. It is also used in prevention of serious conditions caused by blood clots, such as stroke, heart attack, DVT, or pulmonary emboli. If you've had somebody that has had a stroke that is caused by, like maybe by a PE or something like that, they will go ahead and give them blood thinner because they don't want that blood to clot and to cause a stroke. And Lonnie will talk more along those lines with that. But when you will see stroke a lot of times, or a heart attack, the anticoagulant given, and just think, it's to keep the blood thin, to prevent the formation of any future clots. It's not dealing with a clot that's already there. Just remember, anticoagulant is to prevent future clots. Okay, contraindications found on page 416 of your book. If you want more information, you can also pull up your Davis Drug Guide and also look at that and see, more detail about it. You can if you do not already have on any of these drugs that we are talking about through this power slide, you do not have a drug card made out for them, I strongly suggest maybe you go ahead and you do it and you get it done. That way you're, one step ahead of the game on it, and it will help you also when you're studying for your test. It might help kind of get some of this information into your head so you understand what each one is for. So contraindications. Why would we not go give an anticoagulant? You're not going to give it in a known allergy. You're not going to give somebody that is allergic to this medication, like heparin or Coumadin. You're not going to give them that medication if they're allergic to that medication. There are other meds that they can give, not necessarily a coagulant, but there's like an antifibrinolytic, and they could probably do an antifibrinolytic along with an antiplatelet or something like that to help them. There's also an alternative, maybe an alternative medication that they can give with it. That's also why it's very important when you're doing your history and physical that you also look at your patient and they say, I'm allergic to this, you need to ask them, so what happens when you have it? If they say, well, whenever I take Coumadin, I get a bloody nose. That is not necessarily in and of itself an allergy. It's just a known side effect to it. So maybe the dosage is off. Maybe they're not being compliant with their blood work. Acute bleeding. So question being, would you give somebody that is bleeding something to thin their blood more? No, you would not. And you would not give them to somebody that is at a high risk for thrombocytopenia. Now, low molecular weight heparin, you're going to see it abbreviated LMWH. These are contraindicated in patients with indwelling epidural catheters. Somebody that's had, an epidural catheter maybe because they've had like a C-section, or they've had an epidural catheter, they've had the block for some surgery. So they're going to hold off for 2 hours, a minimum of 2 hours after the epidural is removed. Then they can go ahead and give it because they want that spinal fluid that's in the epidural cavity to seal it off. So if you give somebody a blood thinner, it's going to thin things off. So you don't want to do that. So the recommendation is that best practice is you just do not do that until it's been 2 hours, at least a minimum of 2 hours after the epidural catheter has been removed. And in pregnancy, it's contraindicated to give Coumadin. They will do heparin. Heparin is recommended in pregnant people. Coumadin is not. And I'm sure that was talked about in maternal child, so enough with that. Okay, so now we're talking about adverse effects. Bleeding is the main complication. The risks increase with increasing dosages, so the higher the dose, the higher your risk of this complication is going to be. But sometimes this is a case of where the benefits outweigh the risks. This is why we have labs that we monitor. This is why we do assessments. This is why we watch the person. This is why we tell them, okay, if you see any blood in your urine, if you brush your teeth and you notice your gums are bleeding, please notify us immediately. Also, another side effect is heparin-induced thrombocytopenia, or HIT. You will see that in side effects with that. Type 1 is characterized by a more gradual increase in platelets. Heparin therapy can generally be continued. Type 2 has an actual fall in the number of platelets, and heparin therapy must be stopped. So with the HIT, you're monitoring the platelet levels, and if they're pretty well staying steady, or maybe there may be just a drop of a few in the platelet count, you might go ahead and continue the heparin therapy. But if there is a big decline with it, a big fall in the number of platelets, then you're immediately going to stop the heparin therapy. You're going to check for heparin, you're going to check the platelets, you're going to look to see, and if the platelets are where the doctor wants them to be, they're okay. But if they've had like a big drop from 100,000 down to 90,000, you're not going to administer the heparin. You're going to pick up the phone and you're going to talk to the provider and say, hey, this is what this last lab is. What do you want me to do? They're due for heparin. They're due for this much heparin. What do you want me to do? And 9 chances out of 10, they'll probably say, hold the heparin and redraw the lab in a couple of hours, or redraw the lab and let me know what the lab is with that. Okay, Now on to the medications of anticoagulants, the most commonly used ones. There are several medications out there, but like I said at the beginning, we're going to just kind of focus more on the most commonly used ones. And throughout there, you'll see little red boxes that say high alert. It's not on all of them, but it is sporadically put out there. Any blood thinner, any antiplatelet, any fibrinolytic, they're considered high alerts because it alters the bleeding or the clotting factor of the blood. So you want to be careful. So we're going to start off with probably the most commonly used one, the one that everybody I know should have. If they do not, they need to have a drug card for Coumadin or warfarin. This can be found on page 410 to 420 in your textbook. It's also found in your Davis Drug Guide. So let's begin talking about Coumadin. Okay, this is the pharmacokinetics for Coumadin. As you can see, it's given orally. Its main route is through the mouth. Onset of action, the time it takes for it to work can be anywhere from 24 to 72 hours. Peak plasma concentration at the peak when it's working the most effectively is at 4 hours. The elimination half-life is how long it takes for it to get eliminate exactly half of it out of the system, which would be 0.5 or half a day to 3 days, and the duration, how long it's going to last, which is 2 to 5 days. With it, you can also see the different dosages of Coumadin down here. You can see that it's scored, and they do that a lot mainly because, not that Coumadin is expensive, but some people change their Coumadin dosages frequently, so they pretty well will, the doctor will start them out on one dosage, and the pharmacist will also explain them, but this is part of the education. Tell them, get a really good pill cutter. The doctor is starting you on 2 milligrams 3 days a week, and 1 milligram 1 day a week. He may change it. He may want you to take 2.5. So if you have 1 milligram tablet, you can cut that in half, and you can take your 2.5. So just kind of depending. So sometimes it gets to be kind of crazy with it. My grandma, for example, she was on, I'm guessing, the last time she was on, before she passed away, her dosage of Coumadin, she was getting 3 milligrams twice a week, and then she would take 1.5 milligrams. So we were having to cut one of her, her 1 milligram tablets in half, and give her a full tablet and a half of a tablet with it. But, there were times that she was taking 3 different dosages of it. And we just had enough of several, and it was lucky enough for us that at one point in time it was like 2.5, so you could cut half of a 2 to give her 2.5. It got to be kind of confusing, which is why the biggest problem is overdosing of it, or your blood getting too thin on it. Happens a lot because it can get kind of confusing with it. So that's why you need to be very careful about it, but that's why they really need to have really good education with it. And you can see each pill is a different color, and that also helps. It's kind of like a lavender color, or it's a green color, or it's a tan color, it's an orange color, or really bright pink color. So the 1 milligram, 2 milligram, and 3 milligram tablets are given the most commonly. 5 milligrams, not very much. I've seen very rarely the 6 or the 7.5. I've not seen anybody get 10 milligrams of Coumadin, but typically between the 1, 2, and 3 milligrams, that's the one that you usually see, because sometimes you'll see them on 4 milligrams, which means they can either take, if they have a 3 milligram and a 1 milligram, they can take a 3 and a 1, or if they got the 2 milligram, they can take 2 of them. Or if they've got 2.5 and they've got a 1 milligram and they need to take 3 milligrams, and they can take the full 2.5 and cut the 1 milligram in half, which will give them a half, which will then give them the 3 milligrams with it. So see why it's very important to kind of understand your math on this part too. But no, Coumadin, like I said, is the most commonly used anticoagulant. It's given orally. It's a pill. It's easy to adjust the dosages with it. So it's just sometimes just trying to keep track of what it is. So it's very important for them to write it down. If you're in a doctor's office, it's very important for you to write it specifically down. On Monday, Wednesday, Friday, take 2 milligrams. Tuesday, Thursday, take this amount. Write it down to where they understand it. Take 1 2 milligram tablet, or cut your 2 milligram tablet in half. However specifically, you know, you need to be very specific with it. Okay, Coumadin, page 419. Continuing on. The mechanism of action is it interferes, like I said, we talked a little bit about this earlier. It interferes with the synthesis of clotting factors. The indication is given to prevent secondary thrombolytic complications. The contraindications, they're going to, if there's a problem with blood clotting, or the person is pregnant woman is needing to have an anticoagulant, they're going to go to the site of heparin before they will Coumadin with it. It is the most commonly used. They're not going to give you a blood thinner if you have an open wound, because it's going to bleed and you're going to have problems. Active peptic ulcer, that's a bleeding ulcer. You don't want to give somebody a blood thinner if they are on it. Now, something you need to be very careful of, that you need to be very familiar of, is the drug interactions. These are what's going to interact with Coumadin that's going to cause increased bleeding. So you're going to have antibiotics, a lot of antibiotics. They will adjust the PT-INR. They will do frequent blood work on them. Just like with when I talked in the endocrine system about steroids, the same thing goes with antibiotics, especially with people that are on anticoagulants. Vitamin K, you need to be very careful. Tell them to be very careful about eating a diet high in vitamin K. You know, like your dark green leafy vegetables and stuff like that. They need to eat a well-balanced meal, but they need to be very careful about how much vitamin K, because that will increase some bleeding issues with them. Herbal medications need to be very careful. Tylenol, alcohol already thins the blood, so if you're drinking a lot of alcohol and you're taking a blood thinner, you're going to have a problem. NSAIDs are the same way. Amiodarone is the same way. So the rule of thumb is you need to tell them, you need to educate them to say before they start any new medications, they need to clear it with their provider. Adverse effects that we're talking about, these are some more of them. You're going to have nausea, diarrhea, urticaria, hypotension, fatigue, headache, alopecia, hemorrhage. Route typically is oral IV. They do have some IV. I've not seen it. I've just heard about it. I don't know of any that has been given here, or I haven't dealt with it in the 24 years that I've done nursing with it. And like you see, like you've seen on the previous picture with the different dosages of it, it can be anywhere from 2 to 5 milligrams per day, 2 to 4 days a week, then adjusted based on PT, on your prothrombin. So it just depends. Your dosages can be fluctuating. Everybody's going to be a little different on how they get it, how often they get it. You know, some people, if they come in and you're working like in a doctor's office and they're complaining, they're saying, every time I come in, you're changing my Coumadin levels. Get a detailed dietary history and a medical history with them. You might be surprised, you might, print off a list of herbal medications and say, are you taking this, 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 and this? And if they say, oh yeah, I am taking that, that might be why their PT-INRs are not within normal limits. Just a little thing about helping you, maybe the visual learners, about the Coumadin medication, your warfarin. Coumadin is what you're going to hear it the most commonly called, though. Okay, patient education and teaching. Watch for you're going to teach your patient to watch for unusual bleeding, like bleeding from the gums, blood in the urine, black or dark tarry stools, nosebleed, emesis with blood in it, and sometimes an unusually severe headache that does not go away with medication. That could be a brain bleed with that. So these are some of the things that you're going to tell them. Okay, if you're brushing your teeth and all of a sudden you notice your gums are bleeding, call us right away. These are the things that you're going to need to stress with them, especially with discharge planning. It needs to be on your care plan. It needs to be addressed with them. You need to educate them as soon as they get started on it and before discharge, what to watch for and what to do if they notice any of these. A lot of them are not medical emergencies. A nosebleed that will not stop bleeding after 2 to 3 minutes needs to go to the ER, especially if they're on Coumadin therapy. Another thing is also having them get a medic alert bracelet, so if they're in an accident and they're not able to answer questions themselves, the person coming across the accident will say, okay, this person is on a blood thinner. We need to put this into action with it. sorry I forgot my header on this page. I apologize. Just some more patient education with them. You educate the patient to use a soft bristle toothbrush. Tell them to look for it, find a soft one. Never use a straight edge. Use an electric razor. Be careful around sharp objects. That's kind of an obvious thing. Notify provider you are on Coumadin before any surgical procedures. Visit with your dentist before having any dental work done. I hope that's kind of been explained in previous slides. Take at the same time every day. If you miss a dose, do not double dose. Eat a well-balanced diet. Be careful of eating too much vitamin K enriched foods. These are some more patient teaching things. These are some of the things that, as you're educating your patient, when we're talking about a care plan, the expected outcome is patient will verbalize understanding that he will need to use a soft bristle toothbrush, will not shave, will get rid of all of his straight edged razors and use an electric razor only to shave his face, and will visit with all his healthcare providers before any surgical or invasive procedures that he is on Coumadin and follow their recommendations. Those are things that when you have somebody that has an anticoagulant type care plan, those are the interventions and stuff, outcomes that we are expecting to see on there. Moving on to Lovenox, found on page 418. Lovenox or enoxaparin is an anticoagulant. It is given subcutaneously. It is also one of these that they can use for carryover. We call it carryover or bridging. A lot of times you have somebody that's going to have like a steroid epidural injection, a surgical procedure, a dental procedure, they're on Coumadin, and they need to be on it because of whatever reason. They may have AFib or something like that. They're going to do a process to where they're going to do a PT-INR. They're going to see where their level is, and then they're going to adjust the dosage of Lovenox just to make sure, it's kind of a complicated thing. They're going to do the Lovenox. The thing to remember that I want you to understand is they will use Lovenox for those patients that are having procedures and stuff that they can't take the Coumadin for. Even though this is an anticoagulant, it's a lot safer than giving them Coumadin, and it also keeps their blood thin enough it's not going to cause problems with it. On that, it is also considered a high alert medication. The most common way you're going to see it is through the syringes. You don't see it very much in a vial. You see it more in the pre-filled syringes, which are a lot easier to do. As you can see on page 418, this is the pharmacokinetics of Lovenox or enoxaparin. Lovenox is the most commonly used one. It is given subcutaneously. The onset of action is 3 to 5 hours. Peak plasma is 4 to 5 hours. Elimination half-life is 4 to 5 hours, and duration of action is 12 hours. So it's in the system. It gets out of the system a lot faster than your Coumadin. Excuse me with that. Which is why they will tend to use this instead of heparin as the bridging between the procedure and taking them. Okay, mechanism of action. It is a prototypical low-weight heparin, molecular weight, your LMWH, complex with circulating factors. It accelerates the formation of antithrombin 3 thrombin complex, and it in fact inactivates thrombin and prevents the conversion of fibrogen to fibrin. It basically is a gentler form of heparin. It's easier. Like I said, it's a little easier on the system. You don't have to have all these lab works and stuff done with Lovenox. The thing that you need to remember is before you give Lovenox, you need to check platelet count with that. Other than that, it's just a little bit, it prevents the thing to remember about Lovenox is it prevents the conversion of fibrogen to fibrin during the clotting process. So basically, remember, it's an anticoagulant. So it is helping prevent blood clots. Okay, it is used in the prevention of venous thromboembolism or VTE, DVT, which is also known as a deep vein thrombosis, and or pulmonary embolism in surgical or medical patients. Medical patients, we're looking at patients that are bedridden a lot. Treatment for DVT with or without PE, they can use it with Coumadin. This is a complementary when we talked about it. It's also used for prevention of ischemic complications with aspirin for unstable angina and non-ST emergent elevation. It is also used as a treatment for acute ST segment elevation MI. And you can find this information on 632. And we'll talk a little bit more about the MI when we talk about the cardiology medications. But the thing to remember with it, Lovenox is what we will call, you can classify also in the complementary medications, because you can use it with Coumadin for treatment of a DVT with or without a pulmonary embolism. And you can also use it with aspirin in the prevention of ischemic complications from unstable angina or a non-ST emergent elevation MI. Basically, it's a heart attack without an ST elevation with it. So, which may be caused by, AFib. But they're using it in conjunction with, it's a complementary medication treatment with that. Contraindications and side effects. Contraindications, you're not going to give it to anybody that has a pork allergy, active bleeding, HIT. You're going to use it cautiously with hepatic or renal diseases with that, because of the way it's metabolized in the system. Active bleeding, once again, is an anticoagulant. You're not going to do that. Adverse effects, you're going to be monitoring for any bleeding, dizziness, headache, anemia, or hematoma. Hematoma is like a big, nasty, kind of like a purpley bruise. It's where a blood clot is forming under a certain area, maybe under a puncture, and it's just like a hard mass. It can cause anemia, because remember, it's coagulant is causing thinning of the blood, so it's causing problems with that. So dizziness, it could be because there is excessive bleeding going on. So that would be the problem with that. So that's why you're watching for that. So these are the most common side effects with it. The big one is bleeding. Okay, now with everything, we've talked about side effects, we also need to focus on the drug to drug. There is a risk of increased bleeding may be caused by concurrent use of drugs that affect platelet function and coagulation. So there may be increased bleeding if you're using it with Coumadin. At the same time, you can for some things, but there may be the increased risk for bleeding, or aspirin, or NSAIDs, or Plavix. So you're going to want to be monitoring for blood in the urine, nosebleeds, and stuff like that. Herbal medications, and this is just a list of some of the herbal medications that might cause increased risk of bleeding or decrease the body's ability to form a blood clot. It may form a blood clot, but it may take, instead of like a minute, it may take 5 to 10 minutes to form a blood clot, which could be life or death in some cases. Then the route, it is given subcutaneously, IV for acute MI. That's where that multi-dose vial would come in handy. The dosage is standard and is based on weight for treatment. So they're going to maybe give 30 to 40 milligrams 1 to 2 times daily for prevention. The doctor has a formula that he looks at. He's looking at weights in kilograms, and he's going to go however many milligrams of the medication he wants to give per kilograms the patient is weighing, basically. But the standard dosing is 30 to 40 milligrams 1 to 2 times daily for prevention. A lot of times, though, I have given up to 100 milligrams twice daily for people, but that has been the one patient I do know had a mechanical heart valve, and he was having to go in and have a root canal done. So he was, in order for him to stay at the level he needed to because of his heart valve, he had to have that much Lovenox with it. Plus the doctor, when he went in and had his root canal and stuff, the dentist had vitamin K and some antidotes and stuff there with it to help, take care of any bleeding with that. Okay, this is just a kind of a review with the lab considerations, why it's very important to have the lab manual with you. Also read in your drug book, if you do not know what a medication is, you need to monitor the CBC and platelet count. If the platelet count is below 10,000, you're going to discontinue the therapy. It may cause an elevation in the AST and ALT levels, your liver functions. So if you have been noticing that all of a sudden they're on Lovenox, and keep in mind this is going to be a short-term anticoagulant therapy, and you're seeing their liver function tests climb, you will need to notify the provider and say, hey, I've noticed that since they've been Lovenox, their liver function tests are elevated, and he may want to discontinue and maybe switch them over to heparin with that. It is only used for short-term, not long-term anticoagulation. I'm sorry, for some reason I must have hit enter on that. Typically with this one, you don't monitor the PTT levels. That's typically, you're going to see that with Coumadin. You're going to monitor more the platelet count on this one. The patient teaching on this one is going to be the same thing with Coumadin. You're going to monitor for bleeding. Do not take any over-the-counter medications, especially aspirin, unless specifically directed by the provider. Injections in the abdomen should be 2 inches from the umbilicus or any incisional site. If they have an incision on the right side, just tell them to rotate it over on the left side. Don't even go anywhere near the right side of it. Do not expel the bubble from the syringe. It is there to keep the medication in. If needing to give a partial dose, there are dosage lines on the syringe. So if all they have up there is 40 milligram syringes and you need to give 30 milligrams, pull the cap off, inject it, and give it down to where there's only 10 milligrams left in the syringe. You do not expel that bubble, because if you do, you're wasting medication and they're not getting the full effect of their medication on it. It is therefore a safety thing with it. Okay, for our visual learners, this is for Lovenox. It shows that thou shalt not develop clots or ischemia. It's given better to prevent than to treat clots. Be sure to use bleeding precautions when using Lovenox. It shows a little, I'm guessing it's a little dog or a mouse using an electric razor. This is a high alert medication. Remember, this is one of those medications that increased, thromboembolism. The risk for that is increased because of the medication with it. So hopefully this is just something that will help you with the ones of you that, maybe are more of a visual learner. Okay, heparin, page 419. It's also in your Davis drug book. Route, it can be given one of 2 ways. It can be given subcutaneously. Onset of action is 20 to 30 minutes. Peak plasma concentration is 3 to 4 hours. Elimination half-life is 1 to 2 hours. Duration of action is 8 to 12 hours. Intravenously, the onset of action is immediate. Peak plasma is immediate. Elimination of half-life is going to be the same as subcutaneous, 1 to 2 hours. Duration of action is dependent upon infusion duration. So basically that is just saying that the duration of action is going to be dependent upon how long you're going to run your IV heparin drip. If they're going to only do it for an hour, then the duration is probably going to be just an hour with that. It is a high alert medication. If you see over here facing the computer screen on the left-hand side, you've got vials of heparin. These are different ways that heparin comes in, different weights, different dosages. This one has 1,000 in it. If you look over here on the underneath the red highlight, the yellow syringes, you will see these probably more back in the surgical area, but it's also used in a lot of facilities because the best practice on certain central lines and stuff is to flush with normal saline, then do a hep lock on it. So this is just another form that heparin comes in. As you can tell with mechanism action with all anticoagulants, it pretty well is basically the same thing. They are there to prevent the development of a thrombus with it. It's through one way or another, whether it's through preventing the fibrogen, turning to fibrin, whatever. The whole essential thing is going to be prevention of a thrombus. Okay, heparin indications. Arterial and venous thrombotic conditions including AFib, prophylaxis, and treatment. Rapid acting within minutes to prevent and treat DVTs and PEs. Used to treat disseminated intravascular coagulation. Preferred anticoagulant in pregnancy, we talked about that. And prevents coagulation in heart-lung machines and dialyzers in patients after open heart surgery. It keeps the blood really thin, so it allows it to go through the dialyzers and stuff in the heart-lung machine when they're having open heart surgery, heart transplants, and the like with that. They like it because it's rapid acting. It acts within minutes to prevent a DVT or a PE on that. Heparin contraindications and side effects. The contraindications are renal impairment. It's not going. If you have renal impairment, it's not going to be excreted like it needs to be. Hypersensitivity to pork products. Severe thrombocytopenia. They're going to bleed more. If they have like hemophilia, they have a dissecting aneurysm, they have a peptic ulcer, issues that are going to put them prone to bleeding, they're not going to give it. Postoperative patients, especially people that have had maybe eye surgery, brain surgery, spinal cord surgeries, they're at a risk for bleeding already, so you're not going to give them heparin at this point in time. Adverse effects are the same with anything, hemorrhage, fever, thrombocytopenia, anemia. These are the things that you need to be watching for. Also, these are the ones that you need to be educating during patient education with a patient that is going on heparin, because some patients can go home and do go home on heparin and can, do self-administration of sub-Q shots. Route of administration is IV, subcutaneous. If you have somebody that is having a heart attack or has a DVT or whatever, you're going to see IV, if it's especially an emergent one. Then they will do maybe treatment sub-Q after orthopedic surgery. Sometimes if they don't want it, they need something a little bit stronger than Lovenox, they will go ahead and do sub-Q heparin. Dosage is based on coagulation monitoring, 5,000 units every 8 to 12 hours prophylactically to prevent thromboembolism. That's the typical standard dosage. Drug-to-drug interactions, refer to Lovenox. They're going to be the same thing with that. And patient education, refer to Lovenox and Davis Drug Guide. I'm not going to go over it. It's going to be the same thing. All anticoagulant patient education is going to be the same. That's the biggest thing. When you're doing your care plans and you have somebody on heparin, you need to have on there at risk for bleeding, at risk for injury, and put down the interventions. Why, as evidenced by they're on heparin related to DVT prevention, whatever, the expected outcome is the person is not going to bleed to death, for one. Another expected outcome is the patient is going to report back to you, is going to verbalize back to you, demonstrate how to safely give a Lovenox shot, a heparin shot, before they go home. Those are the things we're looking for. Remember, we want you to be specific. So if you have somebody that is on heparin, put the dosage down and the frequency down. If they're on Lovenox and they are getting 40 milligrams of Lovenox twice a day, put down, patient is receiving Lovenox 40 milligrams twice a day. Monitor platelet level daily or every other day, however the doctor has it ordered. So be specific. This is part of the education you're going to be doing for the patient while he's in the hospital for them to go home. But it also is what needs to be and what especially I'm looking for when you write your care plans. Just another visual learning aid, hopefully to help you with maybe understanding heparin. Antiplatelet mechanism of action. This is another class of coagulation modifiers that prevent clot formation. They're the antiplatelet. Remember what part platelets play in the formation of a thrombus. Antiplatelet drugs work to prevent platelet adhesion to the site of the blood vessel injury, which actually occurs before the clotting cascade. So remember the steps in the clotting cascade. This is what I kind of want you to kind of remember. There's the injury, there is the adhesion, the gathering, the sticking together of the platelets, the start of the clotting cascade. And what antiplatelets are doing is they're taking care of it so it doesn't, this is just a step to prevent, to prevent the formation of a clot by going after the platelets of it. Instead of going after the fibrin, it's going to go more after the platelets. Indications and contraindications, you can find these on page 422 in your book. The biggest thing is I want you to know is the indication of it is going to be for the therapeutic effects of antiplatelet drugs depend on the particular drug. So the reasoning why is going to kind of maybe depend more on that. The biggest thing I want you to remember about antiplatelet is they reduce the risk of thrombotic stroke, decrease platelet aggregation, and prevent thrombi formation. Remember, the blood clot formation. How they're going to do it, they're going to prevent it from they're going to go, basically just think of it as antiplatelets prevent the platelets from gathering together, having a party, sticking together, to start the formation of a blood clot. They are preventing that. Where the anticoagulants prevented, like the fibrin and all that stuff, from gathering together, this is going after the platelet part of it. Contraindication, once again, allergy, active bleeding, leukemia, traumatic injury, GI ulcer. As you can see, we want, as we go through these, you're going to see a big thing. Active bleeding. You're not going to give somebody something that's already to thin out the blood if they're already bleeding. You're not going to give these to a hemophiliac because they already have problems with blood clotting with it. Recent stroke, we're looking at recent stroke within the past 2 months with that. Okay, side effects and interactions. Adverse effects are basically, if you think back to what anticoagulant are, same thing: drowsiness, dizziness, on some of them bradycardia, hypotension, edema, chest pain. The interactions are going to be NSAIDs and anticoagulants. You're not going to give these typically together. You might, in a rare case, give them something like that, but typically you're not going to. Probably the most common one you might will be the aspirin. Give it along with an antiplatelet with somebody that has had a heart cath to prevent, help keep the blood thin so it doesn't cause a problem. With me, with my heart cath, they had me on Plavix. They also had me on a baby aspirin, which I'm still on, because they figured my chest pain came from where I had maybe a little piece of plaque starting and it tore away and it caused some bleeding, but he wanted to keep my blood thin so I wouldn't develop, as that spot healed, I would not develop a blood clot that would cause a problem. So a lot of times they will do something like that. Aspirin is considered an antipyretic, but it is also considered an antiplatelet. If you look on page 423, it talks a little bit more about that. And also look in your Davis Drug Guide also. The route is given PO. Onset is 15 to 30 minutes. Peak concentration is going to be a quarter of an hour to 2 hours. Elimination is 2 to 3 hours. And duration is 4 to 6 hours. I just included some most common ones. Most commonly, they're going to have you take 81 milligrams. They also will give you, and the 81 milligrams is considered a low dose. So if they tell you low dose, this person needs to have a low dose of aspirin, they're talking about the 81 milligrams. Aspirin 325 milligrams, some people do take that. It just kind of depends on your provider. Typically 81 milligrams is what the American Heart Association and Cardiology also recommend. I also put on here St. Joseph's low dose aspirin chewable. This is what you're going to see in an ER, typically, because if you have somebody coming in with active chest pain and stuff, they're going to give 81 milligrams of aspirin and they're going to want you to chew it on that. So that's why, I have that on there. The other thing to kind of remember about aspirin is if they have an aspirin allergy, you need to ask them, do you have an allergy to aspirin? Because some people do have allergies to aspirin. So you won't want to give it to them. So you'll want to be, as soon as the doctor gets in there, you'll want to tell them this person has an allergy to aspirin. I'm not giving them aspirin, and they'll give them something else for it. Okay, mechanism of action is it counteracts the action of the thromboxane by dilating the vessels and inhibiting platelet aggregation. Basically, aspirin is just preventing the platelets from gathering together. It is given to prevent. It is given to prevent DVT, MI, stroke, no action on formed clots. So this is another preventative. It isn't going to do anything if the clot is already formed. It is there to do something to prevent. Contraindications are the thrombocytopenia, GI bleed, chronic alcoholism, and pregnancy. Drug interactions, you aren't going to give ibuprofen because ibuprofen does have a blood thinning effect. Heparin, Plavix, or any herbal medications. Once again, with patient education, you need to educate the patient on before you start any medications, before you change any medications. Please call us and talk to us. If it's not PCP, it's a cardiologist. So with me, before I start any medications that my primary wants me to start on because of the medications I'm on, I have to clear them with my cardiologist. Same thing with my cardiologist. If he wants to change things, he needs to visit with my PCP. So there's got to be that open line of communication with it. So you need to really stress that with your patients. You also need to stress with them, the GI bleed, dyspnea, nausea, anemia. Those are the most common ones. Say this is what you need to watch out for. If you notice any of these, please contact the provider as soon as you can. It can be given, aspirin can be given rectally or orally. The most common way is usually orally. Rectally is usually given if the person is having a fever. The usual dose, like I said, is low dose of 81 milligrams, but they will sometimes give 325 milligrams. And that's just depending upon the doctor. Okay, Plavix, clopidogrel. This is found on page 423. It is given orally. Its onset of action is 1 to 2 hours. Peak plasma concentration is 1 hour. Elimination half-life is 8 hours. Duration of action is 7 to 10 days. Plavix is one of these medications. It's an antiplatelet. Anybody that you take care of that has had a heart cath or a PCI that has got a percutaneous intervention where they've had a stent put in, they will be on Plavix for a year, 6 months to a year. A lot of times they will put them on Plavix for at least 90 days. I was on Plavix for 90 days just because of what they thought with me. The doctor was trying to figure out what was going on with me. Some of them are just for 30 days. It's just to kind of make sure that, as they're going in there and, in case they bumped an artery a while, that, they don't get any formation of, blood clots with it. But typically you're going to see Plavix given to patients that have had stents put in to help prevent the formation of a blood clot, but with the platelets getting stuck on the mesh part of the stent. Okay, mechanism of action and indications. We're going to give it to suppress platelet aggregation and arterial circulation. Antiplatelet action occurs within 2 hours of administration. So basically within 2 hours after receiving it, then is when you start really seeing it, the platelets are not going to be gathering with it. It blocks ATP. The indications are prevention of MI and stroke, and it prevents the inclusion of coronary stents. We already talked about it. I'm not going to talk anymore about it. So Brilinta is probably another one. Ticagrelor with it. They give it post PCI to kind of help prevent the same thing with it. So these are the ones. This is why you need to know these, because especially Plavix, it's the most commonly used. This is going to be, you're going to be educating the patient on it, because if you get somebody up on the med-surg floor that has had a PCI, they're in the hospital for 24 hours after they have received the PCI. If you end up working in ICU at some point in time or out on the floor, you're going to need to educate the patient. Okay, you're giving Plavix because you had a stent put in. We're monitoring you for this, or they gave you Plavix. You had a heart cath, and the doctor wants to take it to prevent blood clot formation with it. So that's why you need to have the understanding. That's why I said earlier when we started this, some of this stuff, you need to have an understanding. This one you give orally, so you will be giving it on that, giving it to the patient. Okay, contraindications and adverse effects in drug to drug. Drug to drug is going to be, if you've noticed, is going to be always NSAIDs, aspirin, heparin, Coumadin, herbals with your antiplatelet, because it's going to affect on how it stops the aggregation of the Plavix with it. It could interfere with it. Adverse effects: abdominal pain, dyspnea, diarrhea, bleeding, epistaxis, or bloody nose, rash. If you see, this is part of the education also. You need to tell them, if you have a bloody nose and it doesn't stop after, a minute or two and it continues to be a real heavy nosebleed, come to the ER. Abdominal pain, same thing. Some of the, like rash, not necessarily. You can, rash or diarrhea, unless you see copious amounts of blood in the diarrhea, they can make an appointment to come in and see the doctor. But definitely with abdominal pain, bleeding, or bloody nose that doesn't stop. You're going to not administer it in active bleeding, hypersensitivity, breastfeeding, because it is found in the breast milk. Renal and hepatic disease, just because it's not metabolized as well. So a lot of times they check the renal function and liver function before they give it. They do use it in people with renal problems, but they do use it very cautiously and for shorter periods of time. And you're not going to give it with a peptic ulcer, because that's a bleeding ulcer, and you don't want to cause any more problems with that. Adverse effects: thrombocytopenia, GI bleeding, and neutropenia. This is a continuation of the previous page with it. Like I said, it's given orally. The dosage is usually 75 milligrams. They will start you off with 300 milligrams initially, and then it will be 75 milligrams daily. Usually anywhere from 30 to 90 days if it's a PCI that you've had a heart cath and there's no problems. If they do a drug-eluting stent, most doctors typically will only have them do Plavix for 90 days. Sometimes they will do it up to a year. If it's a bare metal stent, they will be taking Plavix for a year. And another cartoon to maybe kind of help you understand about Plavix. Okay, Integralin. This is one that we do use in heart caths, especially if they've had several stents or if we've removed a blood clot with it. It is only given IV. This is the pharmacokinetics part of it. Duration is 1 hour, peak plasma concentration. It's unknown. Elimination half-life is 2 to 2.5 hours, and duration of action is every 4 hours. As you can see, it's given, and there's just different vials with it. You use both vials with it. On that, we'll talk a little bit more on the next slide. The mechanism of action is it's an antiplatelet. It is meant to decrease platelet aggregation by reversibly antagonizing the binding of the fibrogen to the glycoprotein binding site on the platelet surface. Basically, it goes after the glycoproteins that are on the platelet surface, and it prevents the platelets from gathering together. It is given in acute coronary syndrome and treatment for patients undergoing PCI. Like I said, you do see this a lot of people. We use it quite frequently. Some of the Dr. Farrell used to use it. Dr. Farrell and Dr. Verhilla used to use it more than Dr. Friend uses it. He will use it, but typically, it's kind of a preference thing as far as anti-platelet with it. They would, especially Dr. Farrell and Dr. Verhilla would use Integralin, especially after they did more than one stenting. If they stent the LAD and the CIRC, they've got the patient has more than one stent, they will go ahead and use it. And that's just to prevent any formation of platelets with the stents. Contraindications: active bleeding, severe and controlled hypertension. Adverse effects: bleeding, hypotension, drug-to-drug, increased risk of bleeding with other drugs that affect hemostasis, heparin, Coumadin, NSAIDs, and Plavix. We already talked about route and dosage. It is with the dosage, it's only given IV, and it's given as a bolus, and then it is given as an infusion. So we give it in the cath lab. We will give an initial. We'll mix it up, and we'll give like maybe 200 milligrams bolus, and then we'll run the rest of it once it's fixed in an IV drip. It is all based on patient's weight, so it's taken by micrograms per kilograms. It comes in micrograms, so it's going to be, there's a whole conversion. Luckily, though, Integralin comes with a cheat sheet that we look at, and it says if the patient weighs 50 kilograms, you're going to mix this much of integralin in, this much normal saline, and hang it. For a bolus, you're going to give this much, and then you're going to run it at this rate for this amount. But you still need to be able to do your conversions. You need to understand how to get from micrograms to milligrams and stuff like that. Just in case you can't read that, or you're in a cath lab that doesn't have that. Next, we're moving on to thrombolytics. So here is another thing to maybe kind of help the visual learners understand thrombolytics a little bit better. Okay, thrombolytics are agents that are used to activate the natural anti-clotting fibrinolytics mechanism to convert plasmagen to plasmin. It basically is another way to cause the clot to disintegrate. It works on causing clot disintegration. The medications, the one thing to kind of remember with the medications on this one, the commonly used ones end with ASE on them. So like streptokinase, urokinase, ateleptase, redoplase. These are the ones that just think of. You see the ASE at the end of it. A's part of it is probably a thrombolytic. The main thing about a thrombolytic is it breaks the clot. It disintegrates the clot. This works against a clot that's already formed. So it destroys the substances that form a clot. Tissue plasmagen activator is a naturally occurring plasmagen activator secreted by vascular endothelial cells. It's a naturally occurring thing in the body. The indications for it are they're going to give it during acute MI, arterial thrombosis, DVT, occlusion of shunts or catheters, pulmonary embolism, acute ischemic stroke. They're going to give it to kind of basically, excuse me, break the clot, to go after the clot, to open. They use a lot of thrombolytics. They'll use to open a clotted catheter, central lines, like that. Okay, adverse effects: internal and intracranial and superficial bleeding, dyspnea, cough, and fever. By that, it could be internal. Internal could be like in your stomach. Internally is what we're talking about. Intracranial, it could cause a brain bleed. Something happened in the head. Excuse me. Superficial bleeding, something that's happened superficially, something like a scrape, and they bleed quite a bit with it. It's going to cause, a cough, a fever with it. Interactions: increased bleeding tendencies resulting from the concurrent use of anticoagulants and antiplatelets. You're typically not going to use a thrombolytic at the same time you're doing an anticoagulant, antiplatelet. You may in some cases, but typically if you do, it's going to be used very cautiously. So basically what I want you to know for thrombolytic is just remember that it is going after the substances that form a clot. Is going to break the clot down. Okay, activase or ateleptase, page 424. It can be found in your drug book at 1192. Okay, there are two different forms of this medication. You can see in the picture there is cath flow activase. The cath flow is what you're going to use for your central lines, your IV catheters that you have something that's saline locked and you go to get it and it's it's plugged. You can go in and you can use this to help break the clot away from the tip of the catheter. The other one, the one in the bigger bottles and stuff, this is what they usually will run if they think somebody has a blood clot like in the brain that has from a stroke, whatever with it. It is extremely expensive medication. So this one they use it, but like I said, they use it very cautiously. One of it is because of the cost with it, and the other two is they got like TPK. They've got some different medications that they do use with it. So when we're looking at the pharmacokinetics of it, you see that it's only given IV. Onset action is 30 minutes. The peak plasma concentration is going to be 60 minutes. The elimination is 26 to 50 minutes, and duration of action is more for the one that the bigger vials where you're going to run it in as an IV, and that is going to be dependent on how long you're going to run the infusion with it. Okay, what you're going to do when you do the activase mechanism of action, it converts, like I said, plasmagen into plasmin, which then degrades fibrin present in the clots. Basically, you inject it like through the IV catheter. You've got like a central line that's blocked off. You're using that, or even an IV catheter, and you're injecting it. You're going to inject it slowly. Follow the directions carefully on the vial with it. But what you're doing is you're injecting it, and once it reaches the blood clot, it's breaking it down. It's degrading the fibrin and breaking it down, so that then after like about 20 minutes, 30 minutes, you can go back in and you can flush it, and your catheter is open. The indications, like I said, are acute MI, acute massive PE, acute ischemic stroke, occluded central venous access devices. So you're going to use the bigger vial as a drip for your MI, your PEs, and your ischemic stroke, and you're going to use the cath flow for your central venous devices to break loose the blood clot that's at the tip of the catheters. It's going to be contraindicated in active internal bleeding, history of stroke within the past 2 months, intracranial or intraspinal injury, and aneurysm. With that, you're going to also be monitoring for adverse effects, intracranial hemorrhage, GI bleeding, anaphylaxis, and for the drug concurrent use of aspirin or other anticoagulants. Like I said, if you have somebody, you may use the cath flow activase, and you may use it very cautiously on somebody that's receiving an anticoagulant like Coumadin and stuff. But it's going to be something that you're going to definitely clarify with the doctor on it. But it can be used with that. The other thing is with the thrombolytics, the aminocaporic acid is the antidote for it. So you're going to want to have that on hand, especially if you're going to do the IV infusion for somebody that has maybe have an acute MI or a massive PE, or is having an ischemic stroke. You'll need to have that. You're going to, like I said, really monitor, for excess bleeding with that. Patient education is also going to be just like with your anticoagulant and antiplatelets. You're going to tell them to not smoke, not to use electric razors, not to use straight edge, to use a soft toothbrush, and to control sudden, and if they start bleeding, to apply pressure. And if it doesn't stop after 5 minutes, to get to the doctor if they cannot get the bleeding stopped, especially if they have like a bloody nose with it. Excuse me. Okay, next one is antifibrinolytic drugs. You can find that on page 425 in your textbook. The mechanism of action is the effects are very specific and limited. They do not have any effects outside their hematologic ones. In other words, these are not going to be something that you're going to see outside of what they are designed to do. They're designed specifically to do one thing, and this is what they do. The indications, they're useful in both the prevention and treatment of excessive bleeding resulting from systemic hyperfibrinolysis or surgical complications. Desmopressin is probably the most commonly used one, and this may be used in patients with hemophilia A or type 1 von Willebrand disease to stop the bleeding. And you can find those in your textbook on page 425. Contraindications are known allergy to a specific product and disseminated intravascular claudication, or DIC, with that. Adverse effects, dysrhythmia, it can cause an irregular heart rate, orthostatic hypotension, bradycardia, nausea, vomiting, and abdominal cramps. And the dosage is going to be dependent upon the medication that they give and what it is they're trying to treat. Okay, we're just about done. We're on the downhill slide. Okay, laboratory tests. I know I talked earlier on some of them, about the laboratory tests, so this might be kind of a review of it. So some of the things just need to remember, and these are things that as you get to use them, as you get to see them, you will get more familiar with them. But you need to, be familiar with them. And I'm also uploading on Canvas. If I haven't, I'll double check. But there's, kind of like a ProTime and a PT or a PT-INR kind of like cheat sheet thing for you, so you can kind of get familiar with, the times and the normal ranges and stuff like that with that, lab test. Your partial thrombin time, or your PTT, or activated partial thrombin time, APTT, are some of them that you'll do. They're usually, these you'll see, the PTT and the APTT are usually 1 hour prior to the next scheduled dose of heparin. So if you have somebody on heparin, you're going to see them do the PTT or the APTT. The therapeutic range is 1.5 to 2.5 times control for therapeutic dose. So the range is, you want it with this, you want it to be within 1.5 to 2.5 for a therapeutic dose. So anything above 2.5, they're going to be out of therapeutic dosing. So they're going to be adjusting the heparin dosage with that one. They're also going to be looking at the platelet count. Prothrombin, or PT, is for oral anticoagulants, and that is 1.5 to 2 times control for therapeutic dose. Your INR, or your international normalized ratio, is 2 to 4 times for the therapeutic dose. And then you're going to monitor your platelet levels with that. When you have somebody on oral coagulants, you're going to see the PT and the INR ran, because you want to see what their therapeutic doses are on both of them. Okay, your lab values. PT-INR. The PT is going to be used in conjunction with the INR. You're monitoring coumadin levels with it. INR is considered the international normalized ratio. Think high is bleeding, and think coumadin. Like I said, when you see somebody is having a PT-INR done, typically they're monitoring the clotting factors and the efficacy of coumadin with it. So the INR goes along with the PT to give us the PT-INR. The INR is usually 10 times the PT. For example, if the PT is 10, so the INR is going to be 1.0. The INR is separated into the following indications for treatment. 1 to 2 is normal, 2 to 3 range for a patient with atrial fib. You want them to be 3 to 4 range for mechanical heart valves, and then greater than 4, no more coumadin, the antidote vitamin K. So if you see an INR level at 4, you know there's going to be a problem, and then you need to immediately treat it, and they'll be getting some IM vitamin K with that. I have, it's kind of like a tape measure thing, and it's called an INR that I'm uploading to Canvas to kind of maybe help you guys understand that. And it shows you the INR range from 5 clear down to 0, and it kind of breaks it in where it says undefined range, INR 1 to 2. It kind of breaks it down with that. On the other side of it, it's got factors, and it talks about the human blood prothrombin time. Too much coumadin, it means it's higher, so the bleeding risk is higher. So it means it's going to be, remember, if your level is too high, your blood is too thin, so you are at a higher risk for bleeding. Your blood is a lot thinner. So if your INR will go up, it means your blood is too thin. If the INR goes down, you'll need, your blood's a little bit on the thicker side. So you want to try to stay in that therapeutic range. You want to stay in between 2 and 3 with your INR on that. So hopefully this will help you understand it just a little bit better. It just takes a little bit to kind of get comfortable with trying to understand PT-INR, especially with your oral anticoagulation with it. You can also find this information in your lab drug book on page 434 to 437 with it. Just remember what I want you to take away. The key factor with this part is the effectiveness of Coumadin therapy can be monitored by following the patient's PT. For anticoagulation, the INR, typically we want it to be between 2 and 3 for patients with AFib and 3 and 4 for patients with mechanical heart valves. That's very, very important. 1 to 2 is normal, but stop and think why they're getting it. If they're getting it for atrial fibrillation, then you want it to be between the 2 to 3 range with that. If you do look in your lab book on page 436, there's a table 2-43. It shows you the preferred INR range with that. So it goes, if you're doing prophylactically for deep vein thrombosis, they want it to be 1.5 to 2 for the range. Prosthetic valve prophylaxis, 3 to 4. So they want, this is a very good thing to kind of keep in mind, kind of guide you where they want to be. The key thing is to know why they are on this medication. Excuse me. To have uniform PT results for physicians, it's going to be different. Each physician's kind of a little different, but it also, like I said, depends upon why they are giving it to them. So the results, PT results are given in seconds along with a control value, and the control value usually varied somewhat from day to day because of the reagents used. So the whole idea behind the PT was supposed to be approximately equal to the control value, and some laboratories used to report PT values as percentages, and some don't with that. So in order to have a uniform PT results for physicians in different parts of the country and the world, the World Health Organization has recommended that PT results include the use of the INR. So that is why that you are seeing PT/INR instead of just doing INR or PT. It's giving you a more uniform reading with that. So like I said, it's just going to take you just a little bit to get familiar with it, but you need to start really thinking about it and focusing on it. And one of the things that you need to really just kind of commit to memory that I want you to, if nothing else, take away from this is especially with your INR values and stuff, why are they getting the Coumadin? Because that's going to tell you where they really need to be. If they are getting it because they have atrial fibrillation, then they're going to want the INR values between 2 and 3. If they're just getting it because maybe deep vein thrombosis prophylactically, they've had one, they just are giving it to them because they don't want them to have another one, then they're going to be 1.5 to 2. So it's very important that you know why they're getting it, so you know whether or not to say, like, if the normal range is 1 to 2, but you have somebody that has AFib and their INR range is a 3, okay, you can walk yourself through the process and say, okay, they're in atrial fib, they have a history of atrial fib, they are on it for this. The normal range for a patient with atrial fib is 2 to 3, and kind of go from there with it. Visit, until you get comfortable with it, visit with your provider and stuff with it. The intensivist. That, if you have any questions, never be afraid to ask. Especially with PT-INRs with it. And also the good thing about the lab values anymore is they come with out of range, it's too high, it's too low, so it kind of will guide you a little bit with it. But the biggest thing is just always try to know why they are on their medication, any medication, but especially your anticoagulants. Information when you're given iron supplements. Oral or parenteral iron, um, you're going to need to tell them if, what type of iron they're getting, how they need to take it, how often they need to take it. The different types of irons have, you can take it with food, without food. You need to know that. Patient education with administering iron medications. Our side effects are going to be nausea. So typically they want you to administer the oral iron on a full stomach or with a snack. Diarrhea, constipation. Constipation really is the biggest side effect. It's really not so much diarrhea as constipation. Abdominal pain, black tarry stools, tooth stain. If they're on the liquid of it, it will stain their teeth really bad. Parental iron is dextran. Is iron dextran, and it's associated with anaphylactic reactions. Test dose given. In other words, if you're not sure and you're giving them the iron dextran, give them a little bit and kind of watch them for it and see. They don't give it very much. If you're giving it IM, use the Z-Track method with it. Okay, water-soluble vitamins. C and B are your two main common vitamins that are water-soluble. Remember, water-soluble vitamins break down in the water a little easier. You're given it for deficiencies for vitamin B1, thiamine, pregnancy, liver disease, alcoholism. Thiamine is a really big one, especially with alcoholism and liver disease. Vitamin B2 deficiency, which is riboflavin, inadequate milk or animal product consumption, if they have chronic diarrhea, liver disease, alcoholism. With your vitamin Bs, you're going to see with alcoholism a lot because of absorption in the liver and stuff with it. If they're alcoholics, they're not getting this vitamin and it's not being broke down. If they do get it in their food, and it just causes problems. So a lot of times your alcoholics will get what we call a banana bag, which gives has vitamin B1 in it, which is your thiamine. It also has your folic acid. It also has B12 in it. It's got several other things in it, but it's got a lot of B vitamins in it, especially thiamine, to help with liver metabolism and stuff like that. So these are your most common your most commonly used water-soluble vitamins with it. As with any vitamin, you need to be careful. The best way to make sure that you are getting adequate amounts of vitamins, and this needs to be a patient education, is a well-balanced nutritional diet. To eat, follow the food pyramid, and that should pretty well help you maintain a healthy system. But in some cases, like with chronic diarrhea, like with your Crohn's, or you have liver disease or alcoholism, you might need to have a vitamin supplement. And it's always best to encourage them to come in and get some lab work done to see so you're not taking too much of one vitamin and not enough. The niacin, they give a form of niacin to help with hyperlipidemia. So if you have high cholesterol, they will give you a form of niacin with that. B12, they do give a lot for people that have lack of energy. They will give that. That is an IM injection with that. And vitamin C is ascorbic acid. Increase your oranges, your citric acid naturally can help with that. But like I said, with anything, you want to be careful about taking them, because a lot of them can, are not, if they are water soluble or they have a problem with certain things, with certain parts of their body, it can cause increased maybe bleeding times, cause issues with it. So anything with vitamins, you really just need to be careful with on it, because taking too much can cause problems. The other thing is, if you're taking a bunch of vitamins that you don't need and your body doesn't need to do it, then you're excreting them out in your urine and your stool, and you're wasting your money. So that's another reason why you need to educate your patients that, before they start taking all sorts of vitamins that could interact with medications they're already taking, they need to come in and have some lab work done to see if they actually really need to take that vitamin. And it's the same thing with your fat-soluble vitamins with that. Your vitamin A, D, E, and K are your most commonly used ones. Vitamin deficiency K is in newborns, liver disease, long-term TPN, and some medications. So you need to be very careful with it. With that one, encourage dark green leafy vegetables if they can. If it's a baby, that's why they get vitamin K. A lot of times they get vitamin K when they're newborn, especially if they're premature with that. Okay, some misconceptions about vitamin supplements. They're substitute for a poor diet. Excessive vitamin consumption is beneficial with no adverse effects, and vitamins can increase energy level. Like I stated earlier, and stuff with it, a lot of it is we get what we need for our bodies to utilize in a well-balanced nutritional diet. So we really don't need to have it. If we're feeling like we're needing energy or something, go in and talk to the doctor. Do the education with the patient. Educate them to go in and talk to the doctor and say, hey, you know, I'm feeling very lethargic. I'm not doing all this stuff. Could you please help me get my energy back? They'll run some lab work and see if they actually need to have some more vitamin B12 or something like that. Instead of just going willy-nilly saying, oh, look, this one says it's for memory. This one says it's for energy. This one will help me with my sex drive. This one will help me with, you know, grow my hair. Get some lab work done to see if actually your body is missing it. It might be you have something else underlying going on, and the vitamin isn't going to do it. It's not a substitute for a poor diet. You can't just go keep eating junk food all the time. You need to eat, you know, a diet following the food pyramid to help make sure that you have adequate nutrition, and that will help take care of most of them. You know, don't drink a lot of pop. Don't drink a lot of, you know, energy drinks, which can leach out, you know, calcium and the vitamin D out of your bones and stuff. Drink your water, drink your milk, drink, you know, if you feel like you have to do it, compensate and say, okay, for every one of these Red Bulls, I'm going to drink 2 glasses of water, whatever, and kind of equal it out to keep your system, you know, healthy with that. But don't just go get a vitamins because you're tired and you think it's going to boost your energy. For one, it might be because you're in nursing school, so, you know, you're not necessarily going to improve your energy by taking a vitamin. What's going to improve your energy is once you graduate from nursing school with that. But just be very careful. These are the most common misconceptions about vitamin supplements. Now, here are some indications for in case you need has some issues with your calcium, potassium, phosphorus, and magnesium. Women who are at high risk for osteoporosis, who have had like a bone scan done, or who have a family history of it, or who know that they are at risk for osteoporosis, need to take calcium. But in order for calcium to be absorbed into the body, it needs to be taken with vitamin D. Phosphorus for patients with kidney disorders, so they will be on a phosphorus supplement. Potassium for preventing or treating hypokalemia. A lot of times they will just say eat potassium-rich foods. You're not necessarily going to take a vitamin supplement, but sometimes you will, especially if you are on a potassium-wasting supplement, a diuretic. Magnesium for seizure prevention in eclampsia, also laxative or acid abuse. Also, they will sometimes give magnesium for leg cramps too, if you have like restless leg syndromes and stuff like that. So before you go in and take, you know, especially potassium and magnesium, which can also affect your heart rhythm and stuff, go in and have some lab work done and see if actually that is what you need, or if maybe you're deficient in something else. I've already talked about some of this. We'll just quickly go over this. So information to provide your patient during patient education is correct vitamin deficiency with diet when possible. Encourage 2 liters of fluid daily divided throughout the day. Teach women of childbearing age about folic acid. If they're young and they're thinking about getting pregnant, tell them to you know, eat foods that are high in folic acid. Take folic acid supplements when they find out they become pregnant, to prenatal care and prenatal vitamins. The recommended daily amount is RDA is the amount of vitamins needed to prevent deficiencies. So this is another reason. Don't overdo. Don't go past. If the RDA is 500 milligrams of vitamin C daily, don't think 1,000 milligrams is going to be better. Take what is recommended daily to prevent the deficiency. But If you're not deficient in it, then you don't need to be taking it. So in order to figure this out, you need to have a conversation with your provider. Okay, herbal medications are not regulated by the FDA, so each brand is going to be different with it. The only thing that really the FDA really has to say about it is it requires a label. And in 2007, the Dietary Supplement and Non-Prescription Drug Consumer Protection Act added more requirements for labeling and safety. Indications for herbal, so they're safer. It's supposed to tell you what is in there, if there's what the fillers are inside the capsule with it. So indications for common herbal remedies: echinacea, ginkgo biloba, St. John's wort, garlic, saw palmetto, ginseng. So these are just some of the most commonly used ones and the reason why you might be taking them. But once again, use them cautiously. Don't use them for long-term effect. Do a lot of patient education with it. Garlic is known to reduce cholesterol and blood pressure, and it is an anticoagulant. So if you have somebody that is taking Coumadin and they want to take garlic, they really, need to be visiting with their provider. But also, then again, this is another thing, is if you have somebody that is on anticoagulant and you cannot regulate their PT-INR, ask them, are you taking any over-the-counter garlic? Are you eating a lot of garlic? And that might kind of lead you, yeah, I'm eating a lot of garlic. I take 2 garlic tablets every day. So this could be a sign that your blood is too thin, and this is why we can't control it, is you're doing garlic. So this is why, once again, a very detailed medication history is important. Advantages and disadvantages of client use of over-the-counter medications. Advantages is they do not require physician order. Patients can treat themselves. You can hunt and pick and choose, the dosage, the size of pill bottles, the cost of it. No appointment is needed. It saves time and money. The disadvantage is wrong drug chosen, wrong dosage chosen, not too high, not high enough. Over-the-counter interactions with food, herbal prescriptions, impaired ability to function safely. Treatment is ineffective, and disease may progress. You may, like we talked about with garlic, they may be taking garlic and they may be on Coumadin, and you cannot regulate their PT-INR. That can be a problem in and of itself. So that's why it's very important, to do the education. If you have somebody that likes to take a lot of herbal medications or over-the-counter medications, educate them. We need to be educating them before they go home, especially if they're started on a new medication. You need to be able to tell them, okay, be careful what you do. Do not start any new medications, over-the-counter, herbal, or anything until you talk to your provider about them, unless the doctor has said it's okay for them to go ahead and restart their St. John's worts, their sal palmetto, their horny goatweed, whatever it is that they're taking and stuff, if the doctor is aware of it. So this is where, once again, you've heard me say throughout this whole thing, communication. Communication is a very important and integral part of any pharmacological health history and education and treatment with it. So this ends your voiceover PowerPoint. I will, like I said, I will be sure to to have uploaded that PT or that INR chart range. I also have on Canvas for you to do the study.com. There are some worksheets there for you to kind of work through with this. Hopefully that will help you with it. You know my email, you know my office hours, so if you have any questions, please feel free to contact me. I hope I didn't confuse you too much with the hematological pharmacology with it.